Hi everyone, this is Chris, and my classmates Peter, Tiffany, Shivangi, Rick, and myself put together this video to present to you our patient who suffered a right-sided stroke that resulted in left-sided hemiparesis. During our presentation, you'll see an analysis of his movement, his differential diagnosis, and a training circuit that we created for his rehabilitation. We'll start now with his movement analysis. The patient performed one bout of sit-to-stand in 7 seconds. He donned an AFO on his left lower extremity and started in a short-seated position on his couch with his feet flat on the floor. The patient utilized right lateral trunk lean and pushed his right upper extremity into the armrest to help scoot himself further to the edge of the couch. He then pushed off of his right arm again to come to standing. To transition back to sit, the patient reached back for the armrest with his right hand and demonstrated eccentric control without falling back onto the couch. The patient also performed a task where he reached into a cabinet, took out a jar, opened and closed the lid of the jar, and then put it back into the cabinet. It took him 14 seconds to do so. He started by attempting to use his left upper extremity to open the cabinet, but had difficulty with this because of his elbow flexion contracture and decreased shoulder range of motion. In order to reach high enough, he hiked his left shoulder and laterally flexed his trunk to the right, but in the end had to compensate by using his right hand to fully push the cabinet open. He used his right hand to grasp the jar, and then used his contracted left arm to his advantage to help secure the jar to his chest while his right hand opened and closed the lid. He put the jar back and closed the cabinet with his right hand. The patient descended 4 stairs at a speed of 0.12 meters per second. He used a narrow-based quad cane in his right hand to give him stability and utilized a step 2 pattern with his left lower extremity leading. He descended on an angle so that his movement was generated in both the sagittal and frontal planes. He ascended the stairs at 0.10 meters per second in a very different manner than his descent. He chose not to use his cane and instead placed it at the top of the stairs using the right handrail for support. He also used a combination of step 2 and step 3 patterns. What is consistent for both ascent and descent, though, is his use of right lateral trunk lean to advance each step. Finally, we analyzed the patient's ambulation outdoors. His gait speed was approximately 0.39 meters per second. He again utilized a narrow-based quad cane in his right hand for stability and demonstrated a slight right lateral trunk lean over the cane each time he advanced his left lower extremity. The patient has decreased hip flexion, knee flexion, and ankle dorsiflexion, and appears to have greater weakness distally than proximally. He therefore wore an AFO on his left ankle to facilitate clearance of the limb in the swing phase of gait. He also compensated for these range of motion deficits by circumducting his left leg to advance. On the neuromotor processes level, he suffered an infarct on the right side of his brain, resulting in left-sided hemiparesis. He therefore exhibits decreased motor output from both his left upper and lower extremity, which constrains his normal movement sequences.
Some of the clinical signs of stroke that one can present with are weakness and sensory loss on one side of the body, decreased balance and impaired coordination. To confirm a diagnosis of stroke, motor and sensory dysfunction can be assessed by performing manual muscle testing and light touch sensation bilaterally to assess any differences that could be indicative of an impairment. Other characteristics of stroke are decreased static and dynamic balance. To test these qualities, the Burke can be administered. Due to positioning of his left upper extremity as well as gait deviation seen in the video, measuring passive range of motion bilaterally can be used to screen for contractures. To rule out any possibility of spasticity that may contribute to his presentation, the modified Ashworth test can be utilized. In achieving an in-depth observation of range of motion during gait, the program Darfish can be used to measure the patient's joint ranges of the lower extremity during different phases. The stroke rehabilitation assessment of movement measure is an outcome measurement that could be used. This will provide a qualitative evaluation of motor functioning for a stroke patient and monitor the reemergence of voluntary movement and basic mobility throughout the rehabilitation.
Our circuit training routine incorporated various activities and exercises to augment the patient's function. The first station was riding the stationary bike at a comfortable speed for 5 minutes without his AFO. Demonstration of proper form was shown by the physical therapy aid. Along with aerobic conditioning, this station's focus was to serve as a warm-up for further activities. This station targeted lower extremity strength as well as bettering his endurance to improve safe community ambulation. Our next station began with passive stretching of the left upper extremity in the D2 flexion pattern. This was done to decrease the contracted positioning by increasing shoulder external rotation and elbow extension. This was performed for 3 sets with 60-second holds. This same pattern was then incorporated with breathing techniques to assist. Inspiration upon flexion and exhalation upon extension for 5 repetitions. To gain further motion, hold relax PNF D2 flexion was conducted for 5 sets. This station targeted his left upper extremity tightness, which served as a major limitation to many functional activities such as reaching to place dishes in the cabinet or reaching for his toothpaste from the vanity.
The third station was sit and reach. In this station, the patient was asked to sit at the edge of the mat with his right lower extremity supported on a wooden block. The patient was instructed to reach forward towards the cone that the physical therapy aid was holding and to grasp the cone with his left or right upper extremity dependent on the therapist's command. This station was designed to target the patient's ability to reach across the table for his medications while sitting. By having the wooden block under the right lower extremity, weight bearing was increased through his left lower extremity. The patient began reaching with his right upper extremity to practice the motion to gain a better sense of what it should feel like when using his left upper extremity. With this station, the patient worked on decreasing his elbow flexion contracture and increasing shoulder range of motion. By reaching outside his base of support, his trunk stability was also challenged. The next station focused on the patient's left lower extremity strength, targeting the quads, quadratus lumborum, and hip abductors. This station followed a part-whole practice pattern starting with hip hikes in order to improve his ability to ascend and descend stairs. Eventually, the patient progressed to forward step-ups and then side step-ups. The patient wore an ACE wrap on his left lower extremity to prevent foot drop, while helping the patient actively recruit his dorsiflexors. The physical therapy aid demonstrated each activity, and the physical therapist guarded on the patient's left side. For this entire station, the patient performed 2 sets of 8 repetitions bilaterally, starting with the right lower extremity. For hip hikes, the patient was instructed to hold onto the parallel bars while lowering one of his legs off the 2-inch step. The patient then proceeded to elevate his hip without flexing the knees to ensure all motion is coming from the hips. For forward step-ups, the patient was instructed to step up onto the 2-inch step first with the right lower extremity and then lower himself with the left lower extremity. After 8 repetitions of leading with the right lower extremity, the patient focuses on leading with the left lower extremity for strengthening for 2 sets. For side step-ups, the patient was instructed to side step up onto the 2-inch step with his right lower extremity first and step down with his left lower extremity.
This station was a combination of traditional sit-to-stands with a dynamic reaching element. We began this intervention with the patient sitting at the edge of the mat without his AFO or back support. A wooden block was placed underneath his right lower extremity in order to increase the weight bearing on his left. Our PTA demonstrated a sit-to-stand after explanation of the task. The patient then performed a sit-to-stand with use of his upper extremities if needed. A set of practice sit-to-stands without reaching were completed first to facilitate part-hold training. After that, the reaching aspect was added. Upon standing, he reached and grasped the cone in different directions and heights on his left side using both upper extremities when told to do so. The first 2 repetitions covered short distances to allow for the patient's early success with this activity. The patient performed 3 sets of 6 to 8 repetitions at this station. This station targeted strength in both lower extremities with increased focus on strengthening the left hemiparetic side. It also challenged his dynamic balance as he reached for the cone from his standing position. In addition, this targeted the flexibility of his arm and trunk and also worked on his grasping ability. This activity was created with the intention of transferring this training to the home environment, when the patient would have to reach up into a high cabinet or low drawer to grab an object. The final station of the circuit was an obstacle course designed to simulate the environment of everyday community ambulation. He wore an AFO without use of his cane to give him some external control while also challenging him. This was done to work on stamina and focal strengthening of the hip musculature. The course began with a sit-to-stand and then the patient weaved around the cones. This was then followed by a step-up with wedges on either side to force a more efficient narrow base of support and to minimize the patient's circumduction and gait. After this, the patient then sidestepped between 2 cones, beginning with the left foot, then the right. At the end of this course, the patient sat down in a chair to rest, and then repeated this obstacle course in the opposite direction. This intervention focused on dynamic balance as the patient had to negotiate obstacles. It targeted lower extremity strength with the sit-to-stands and the step-ups. Endurance was also targeted, as maintaining his level of endurance is important for his overall function. This course will bring functional carryover for community ambulation. The step-ups were done in order to simulate negotiating curves. Cones resembled weaving or sidestepping through people in crowded areas. These serve as forms of practice in preparation for the many natural obstacles he will encounter in his day-to-day life that need to be addressed. The hope of this circuit was to address as many impairments as possible in order to facilitate functional carryover into the patient's everyday life.